Hello again, it's Dr. Harim Jaffer. I'm periodontist. Today I'll talk about periodontal abscess. Please subscribe to my channel HL Talent to get more videos. As a definition, we have three main types of periodontal abscess. We have, as a term, gingival abscess, periodontal abscess, pericoronal abscess. The gingival one, it's located on the gingival margin and the interdental papilla, while periodontal abscess is localized to the periodontal pocket, and pericoronal abscess, which lead to formation of abscess in the surrounding soft tissue of the crown of partially erupted tooth. And we have fourth type, actually, pulp abscess, but this is not associated merely to the periodontium. It has a tooth factor also. So, the clinical features of periodontal abscess, as you see it here, localized red ovoid swelling, periodontal pocketing, the tooth may be mobile, or the tooth is elevated in the socket, and there will be a tenderness to percussion or on biting on some subjects like cotton roll. And do you find that there's an exudation while probing or sometimes on gentle pressure on the gingiva? And in severe cases, there will be an elevation of temperature, fever, and regional lymphadenopathy. The pathogenesis of periodontal abscess. We have two main factors that are associated with the formation of abscess. For example, bacteria and trauma or local irritants. Both of them, we may have just a trauma or just bacteria, or we may have both of them. And both of them will lead to destruction of connective tissue and the formation of inflammatory infiltrate with the presence of decreased tissue resistance and highly virulent bacteria. So the aggregation of the bacteria with the local irritants and with the presence of decreased tissue resistance, like in case of diabetic patient, and presence of highly gram-negative or virulent bacteria, it will lead to formation of inflammatory infiltrate and destruction of connective tissue. The classification of periodontal abscess, we can classify it on four bases. According to the onset, we have acute periodontal abscess and chronic periodontal abscess. The acute one develop in short period of time and lasts for a few days or few weeks, and it has a sudden onset of pain on biting and deep throbbing pain, and the gingiva become red, swollen, and tender, and sometimes the pus may discharge from the gingival crevice, and also there will be a lymphadenopathy or regional lymph node enlargement. While in chronic periodontal abscess, it will develop slowly and last for a long period of time. The patient may experience a bad odor, nasty taste, spontaneous bleeding, and the adjacent tooth is tender on bite and sometimes mobile. And the pus discharge most of the time could be seen in the chronic periodontal abscess, or sometimes a sinus tract. And the pain is usually of low intensity. Depending on the number, we have either single periodontal abscess or multiple periodontal abscess. And regarding the location, we have either a lateral periodontal abscess alongside the lateral wall of the root, or periodontal abscess associated with the pocket. Depending on etiological factor, we have either periodontitis related periodontal abscess or non-periodontitis related periodontal abscess. I'll talk about it later. So this is regarding the classification. Here we are discussing the etiological classification of periodontology based on the etiology. We have either periodontal abscess in periodontitis patient or in the pre-existing periodontal pocket, or periodontal abscess in a non-periodontitis causes. We have no periodontitis, or we may not have a pocket and we still have an abscess. In periodontitis cases, for example, we may have an acute exacerbation of a chronic process, which is a pocket, untreated periodontitis, and when the patient is not responsive because of the type of bacteria, because of the insufficiency of the treatment, it's non-responsive to therapy of periodontitis, or sometimes the supportive periodontal therapy is not convincing, can't heal the acute exacerbation that happened during the presence of the pocket, or sometimes after treatment of periodontitis. For example, post-scaling and polishing. We are doing the scaling but not removing all the calculus, and the remaining of the local factors subgingivally, it will harbor bacteria and subsequently lead to formation of abscesses and post-discharge. Also, giving medications, for example, sometimes some dentists are using antimicrobials without doing scaling and root planing, just giving medications. And giving medication without mechanical treatment lead to resistance of bacteria, and this resistance will make a layer that make it protective against future antimicrobials, so it will enhance more plaque and bacterial accumulation, and more virulent factor will be aggregated, and it will lead to abscess formation. Or sometimes giving, for example, medically the patient is diseased, like for example they are giving anticonvulsant like nifedipine or cyclosporin for kidney transplant patient, and these drugs are causing swelling, gingival swelling, and the insufficient cleaning under these pockets, pseudo pockets, will lead to formation and aggregation of bacterial aggregate and formation of the abscess, periodontal abscess. While the non-periodontal causes, for example, we have impactions. Impaction of what? Impaction of dental flows, orthodontic elastics, toothpicks, rubber dam, popcorn hulls, or fish bones, or the patient have bad habits like, for example, wire or nail biting and clenching, orthodontic forces, excessive force, or crossbite may cause an abscess formation, or gingival overgrowth for any causes other than periodontal disease may harbor more bacteria and make oral hygiene measures difficult and removal of the plaque more difficult, and subsequently lead to formation of an abscess. Also, surface anatomy, the defect of surface anatomy, for example, severe anatomical alterations, minor anatomical alterations, are also causes of periodontal abscess, because these areas can't be cleaned well, and to lead to subsequent accumulation of bacteria and local irritants. Iatrogenic factors like perforation, doing a failed endo, perforating the root, it will lead to formation of an abscess, or severe root damage, or external root resorption. All of these are part of non-periodontal related periodontal abscess. So simply, if we have a pocket, inadequate scaling, treatment with systemic antibiotic without subgingival debridement, or periodontitis, these are the causes that will lead to periodontal abscess. While the non-periodontal origin abscess is just like here, for example, you can see this creepy endodontic treatment lead to formation of periodontal abscess unless it will be treated. So, for example, impaction of tooth bristles, foods like fish bones, any hard traumatic agents may cause a formation of periodontal abscess of non-periodontal origin. Local predisposing factor, Systemically, when the patient is diabetic, it is the most predisposed one which is prone to periodontal abscess because you have an immune deficient patient and you have a defect in immune response, in the innate inflammatory response. So systematically, diabetic is the risk factor, local predisposing factor, also external root resorption as we talked about, invaginated cracked tooth, furcation involvement, and cemental tears. Like you see it here, for example, this is an external root resorption. It will lead to formation of an abscess unless it will be treated with a good endodontic treatment. This is enough for today. I'll try to explain the other parts, which was the bacteriology and the treatment modalities and instructions in the next lecture. Thank you for your listening.